Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Hypotension and shock are recognized complications post-cardiac surgery. Some patients may develop more severe shock refractory to fluids and catecholamines. In today's podcast episode, we will discuss vasoplegia after cardiac surgery. Our guest is Dr. Iqbal Ratnani, an intensivist who practices at the DeBakey Heart Vascular Center and the Center for Critical Care at Houston Methodist Hospital. Dr. Ratnani is an associate professor of clinical anesthesiology and critical care for the Department of Anesthesiology and Critical Care at Weill Cornell Medical College. In addition, Dr. Ratnani is the Director of Critical Care Education at the Center for Critical Care. A recognized clinician and educator, it is a true honor and pleasure to have him with us today. Iqbal, welcome to Critical Matters.
Thank you very much. It's my pleasure.
So today we're going to talk about vasoplegia, which I think is a very interesting situation at the bedside. And we're going to focus mostly on vasoplegia that occurs after cardiac surgery. But I wanted to start with maybe a broad definition of vasoplegia, also known as the vasoplegic syndrome.
So, Sergio, I will say that vasoplegia in simple terms for the students and for clinician is that it's the loss of vascular tone. Or in other words, when vessels cannot provide enough vasoconstriction in response to hemodynamics. That's a very simple, in simple words. But technically, if we talk about the best definition came out in 2018, and I think that that's the most precise and concise definition on vasoplegia or vasodilatory shock. This is a condition as a profound, uncontrollable vasodilatation due to persistently low systemic vascular resistance with normal or high cardiac index. So that's in total, but I still go when I try to teach students, I suggest it's a loss of vascular resistance or not an appropriate vascular tone. Now, I will just add one more line that if you look at the literature, and that really sometimes shocked me that after so many years with our failures and our trials and tributes and all this thing, vasoplegia, we haven't gone beyond the definition. We haven't talked about the categories or the types or refractory or even gradings. Vasoplegia can even have a grading. We have not done that. So we have only this definition available right now for vasoplegia or vasoplegic syndrome, as it said, because it affects the whole body.
And I think it's important what you mentioned, Iqbal, because technically if somebody is vasodilated and requires vasopressors to support them, they have vasoplegia in a situation like septic shock. But when we talk about vasoplegia with experienced clinicians, they're thinking of a particular subset of patients that is more refractory, more difficult to manage, that has maybe a much more severe vasodilatory situation. And like you said, the lack of a grading systems or clinical guides really make this a very broad concept, but we're going to be talking about those patients that have difficulties in terms of managing them post-cardiac surgery due to the vasodilation. What other conditions, can vasoplegia occur in?
Let me put it this way. If you talk to people who are not clinicians or who are not even doctors, and on the outside, anaphylaxis is the best example as an outpatient in the population. But when you talk about inpatient, 2-3 major categories are sepsis and especially cardiac surgery. And some people, and it can be actually, we don't realize that it can be acute and chronic. And some people may have acute on chronic. We haven't talked about that. Probably we have to keep advancing this conversation like we talk about grading. So like in acute, when people have sepsis, they come and they have acute vasoplegia, or people who get cardiac surgery, especially who get cap plus valve, are more prone. These are the more pronounced, but in hemorrhagic shock, in surgery, and then we often don't recognize or we don't talk about it. Some people may have a chronic vasoplegia going on, like people who have cirrhosis. So if I have to put as a bedside for ICU people, I think sepsis and cardiac surgery. And if you have a patient who have a renal failure or cirrhosis, you have to be very vigilant about it.
Excellent. And in terms of a very practical question as we start a deep dive in our clinical discussion, why should a bedside critical care clinician care about vasoplegia?
You know what? The reason is that simple as that it increased mortality. And this is an independent risk factors. Vasoplegia is independent of any other risk factor. It can increase mortality. And it was proven in 1998, article came out and it says that, and we have put in our reference that it can increase mortality up to independently 25%. And going forward, 20 years going forward, 2 decades, in 2018, though the study was done for the LVAD patient, but they found that those LVAD patients who develop vasoplegia can have actually double the mortality or in comparison to other LVAD patients. So this is just the writing on the wall that increase mortality. On top of that, every time we have a sick patient who goes on pressors, we know that it increase length of stay, and sometimes they get acidotic and they become tachypnic, and we intubate them. So mechanical time. So the mortality, morbidity both goes remarkably up if we don't recognize vasoplegia early and if we don't treat it early.
Perfect. In terms of you mentioned LVAD patients. Could you tell me a little bit about what are some of the known predisposing factors for vasoplegia or risk factors for vasoplegia after cardiac surgery?
Right. Unfortunately, the cardiac surgery patients are more prone to vasoplegia because they already carry the risk factors which are known for the vasoplegia. These are the patients who are before surgery, pre-cardiac surgery, maybe on AC inhibitor, which is very much used for the afterload reduction if they have some sort of cardiomyopathy, and cardiologist has put them on AC inhibitor. Then if they have some sort of cardiac failure, CHF, they may have some underlying renal insufficiency. That also make them prone to go into that. Plus, on top of that, when they go for the surgery, if they have a pump time outside of, and studies have shown that whenever the pump time goes more than 180 minutes, it can increase because the blood is in contact with the pump pipes and all these cannulas, which does not have endothelium. So it can increase the chances of having vasoplegia. So these are these patients, unfortunately, and I talk about AC inhibitors, and studies have shown that beta blocker can also cause, going forward in post cardiac surgery, can cause vasoplegia. So these patients are prime to have vasoplegia with preoperative taking the AC inhibitor, beta blocker. They may have some sort of renal insufficiency. They may go into a long pump time. And on top of that, if this cardiac surgery patients are getting dual surgery for valve and cap together, that by itself sometimes increase the pump time. And so they are very prone. And unfortunately, they are sitting at the perfect target to be vasoplegic.
So in general, really, I mean, for our patients undergoing cardiac surgery, those that have more risk factors, which are, like you said, are more and more common in this population, are going to be right at a higher risk. So it's important to be vigilant about on these patients. Iqbal, could you give us a high-level overview of some relevant pathophysiology related to vasoplegia after cardiac surgery?
You know what, this is an interesting question. And as soon as more I read about vasoplegia and I look into the pathophysiology, sometimes I question myself that vasoplegia after cardiac surgery, vasoplegia after sepsis, vasoplegias are completely different. And if I look into their pathophysiology, it is so complex. Sometimes I question myself that are these different diseases even? And we are just using vasoplegia as a one umbrella term to cover all of them. There may be a different pathophysiology for each different subset, like cardiac surgery, sepsis, or even we talk about anaphylaxis and cirrhosis. This is the most complex pathophysiology of vasoplegia I can think of any other disease, because so many things are involved there. It started. It is one thing which we need to understand, that this is the pathophysiology coming from the endothelium of the vessel wall. And whenever there is a damage or any inflammation or any kind of insult to the endothelium wall, that start the cascade. And one thing which I always try to tell students, that every time when people talk about vasoplegia and they talk about the pathophysiology of vasoplegia, they always mention nitric oxide. But if you remember, and I always tell my student that always pay attention to the terminology, always pay attention to the nomenclature. The actual, and in the beginning when the nitric oxide, it was referred as an endothelial derived relaxing factor. And if you pay attention to that nomenclature of nitric oxide, endothelial derived, and I'm repeating it because it's important, endothelial derived relaxing factor. So whenever there is an insult, nitric oxide level goes up, and as the name said, it relaxes the vessel. And the other important factor is that this nitric oxide diffuses into the neighboring smooth muscles and cause the vasodilatation. And with simultaneously, there are a lot of other things happening: platelet activation, leukotriene addition, and then we have vasopressin, arginine vasopressin activation, and these all, and then potassium pump and calcium pump. All those get activated, and this cost start having decreased SVR. That would we see that people start having dilatation of the vessel, and that cause decreased SVR, decreased blood pressure, and cardiac output goes up. And then when all these things happen, pathophysiology does not stop there. It became a cascade where interleukin 6 and interleukin 8 goes up, and they cause the impaired LV function, causing more problems. And that's how the all this negative cascade just keep going on and on with the negative feedback, and the cycle never stops. And that's why the vasoplegia is one of the disease which is hard to sometime treat, because once this cascade of inflammation goes on, it just creates a cycle which you have to break when you are treating the patient.
And as you mentioned, I think in particular with our cardiac surgery patients, exposure of the blood to the artificial circuits, the surgical trauma itself, organ ischemia reperfusion injuries that are common in these surgeries can all lead to also release of endotoxin from the gut and from the vessel, which usually, exacerbates this problem. The other thing that I read, and I don't know, if you could comment if this is something that has been studied, that also there's a common practice of using cell saver, which is giving blood back to the patient, and that blood might be hemolyzed, and that might also exacerbate this inflammatory cascade. Any thoughts on that?
Indeed. And I should take the blame for it that we did not mention that in our article, which we should have. And I wish reviewers would have asked us to, but this is absolutely true. Whenever you use and higher the amount the cell saver, it can also, and that also tells you when the cell saver volume is higher, it means that patient has more bleeding during the cardiac surgery, and patient may have a hypotension or more pump time, and patient may have a blood transfusion. These all have created another stage with actual pathophysiology to cause the vasodilatation and vasoplegia in the cardiac surgery.
Iqbal, this is, I think, a great overview to lead us down to what we really care about, which is management. What do we do at the bedside? And I think that part of the challenge with these patients is that it is not uncommon for patients to come out of the OR after cardiac surgery into the ICU and have hypotension, require either fluids, require a little bit of vasopressors, but not all of them in our mind are deemed as vasoplegic syndrome. So why don't we talk about the management, and maybe we can start with ensuring adequate preload and cardiac output, and then move on to how you would treat patients that become more and more difficult to treat despite that.
Right. In cardiac surgery patient, one of the challenges is that they may have some kind of cardiomyopathy. So you have to be careful. And people, we did one review article on treatment of congestive heart failure. And as a treatment on the first number one, we put IV fluid. And one of the questions we got from the reviewer that if patient is in heart failure, how it can be, volume could be the treatment. But people don't realize that euvolemia, we target negative balance in congestive heart failure when people are volume overloaded. This patient may still be in the negative balance and may still need to travel towards euvolemia. So first thing we do is resuscitate with IV fluid with the hemodynamic management, hemodynamic measurement. Now, people always when think of hemodynamic measurement, and I know that you have spoke about maximalist and minimalist approach toward hemodynamic monitoring in the past, but I think a good clinician does not need a lot of tools to have a hemodynamic measurement, knowing that it's euvolemia. Like a simple passive leg raising can tell you a lot of things. Or if you have an A-line, which you usually have in the cardiac surgery patient, the all this waving of the A-line with drop of systolic blood pressure with inspiration and expiration will tell you that patient is volume deficient. So first thing is definitely volume resuscitation. And once you assume that, or once you are satisfied that the enough volume has been given and still patient is hypotensive and SVR is low, if you have Swan-Ganz catheter, pulmonary artery catheter in place, and if not, then if it's your clinical judgment, you know that enough volume is given, then you go towards the pressors. Now, talking about the pressors, we have a first line as norepinephrine, but we found that vasopressin sometimes works better, or maybe in combination with norepinephrine works better. So our clinical approach is that start norepinephrine, and if we don't see much response by 5 or 6 months, we actually, especially in a cardiac surgery patient, we are quick to add vasopressin and norepinephrine, and that's where we see the response many times. And we have other pressors available too. We have dopamine, which is now almost going out of the practice, but we have phenylephrine, which we use many times. So we have used all this traditional, but in terms of dosing, if we see norepinephrine is nothing doing up to 5 or 7 mics, we quickly add vasopressin. Now, problem with vasopressin for us is that we have only one trial available, VAS trial, which was done with the dose of 0.03. And studies, one study published in 2005 in intensive care medicine from Europe showed that beyond 0.05, it can cause coronary ischemia, mesenteric ischemia. So with vasopressin, you have to walk a very fine line when you are talking between evidence-based medicine and patient-based or personalized medicine. We usually go up to 0.04, or many times I have to write order in the chart that no escalation beyond 0.04 without MD approval. But that's how we start our management, that we go with, this is the first line management, we go with volume resuscitation, and we see that still the blood pressure is low, and we need to work towards the vasodilatation or vasoplegia. We go with norepinephrine and very low threshold to add vasopressin.
Yeah. And I think an important aspect that you mentioned earlier in the definition is that you would anticipate in these patients, if you have invasive monitoring, which is more common after cardiac surgery than some of our other patients, you would be able to document the low SVR and the high or normal cardiac index, right? Suggesting that volume is not the issue anymore. And the way I understand what you were saying about the catecholamines is you start with norepi, which I think most of us agree, based on the available data, should be first line for most situations, especially outside of cardiac surgery. But it sounds like in this particular case, early use of vasopressin, right, adding that very quickly is a good idea, and that's what we should be thinking of.
Right. And this is where the translation medicine and bench side to bedside. When we look into the pathophysiology earlier, we were talking and the increase and the vasopressin receptors, downgrading of vasopressin receptors in the endothelium that bring this practice of using vasopressin early in the course in comparison to other hypotension situation. So we have a low threshold for vasopressin, and if norepion vaso is not working, and that's why I was talking that we haven't talked in our quest for the treatment for the vasoplegia, we haven't talked about the grading, we haven't talked about the types of vasoplegia, which we need to be now, we should have been done by this now. So if that doesn't work, then we go to the second line of treatment for the vasoplegia.
And in terms of targets, I presume we use the usual targets of targeting a mean arterial pressure of 65 and above. Is that usually what you're looking at?
You know what? I'm glad, Sergio, you asked it. Just yesterday, we had a discussion about that. And I was talking to Ashish Khanna. He has done a lot of work and kind of an expert in blood pressure. And this is the time that we have optimum PEEP on ventilator. We need to know that every patient has its own optimum MAP, mean arterial pressure. So personally, I believe that the era of targeting MAP of 65, we should stop thinking about it. Every patient, every clinician should establish, and that's what we were debating. Are we ready to establish a model where every patient can have his own MAP? And there's one study right now in Australia and New Zealand going called React Shock, which is working towards that to see that what could be the optimum MAP for each patient. And that's the hardest part, I think, in vasoplegia, that some patients may have their MAP very well. Some patients who are cirrhotic and living their life and establish their MAP around 55, 60 even, they may just need a MAP of 60 or 55. And some patients may need, who are hypertensive of their life, they may need a MAP higher than 65. So it is actually more the perfusion of the organ which determines the MAP rather than one arbitrary number of 65 blanketing all the patients.
Yeah, and I think that's a great point, Iqbal. I think we all like simplicity, and it's easy to say 65 and above, but you're right. I think as we develop more and more tools, we might be able to do it in a more sophisticated way, but that doesn't take away that we should, from a conceptual framework, think of or ask the question, what's the optimal MAP for my patient that I'm treating right now? And there are many surrogates that we can use to try to figure that out. And I think it just illustrates once again in medicine that having the right questions is really what drives better patient care. So I think that's a great point. So what happens when we are done with conventional vasopressors such as catecholamines and vasopressin, and we're still having trouble? So we gave fluids, we optimized that, we gave catecholamines, we gave vasopressin. What are some of the non-conventional vasopressors or therapies that have been proposed for the treatment of vasoplegic syndrome?
One of the now has become for us in our institution, and I also go with that and favor that, is the hydroxycobalamin, which is vitamin B12 in simple words. We gave a bolus of 5,000 units right away there, and it's called Cyanokit in bedside, as how it is supplied by the pharmacy and known as a brand name. So we use the word a lot, Cyanokit, but it is hydroxycobalamin bolus. And we have seen that it has worked better for us. Just a few years ago, and still in many institutions, the practice is to use the methylene blue as a bolus and then as a drip. But the thing is that over the last 2-3 years, I'm moving away from methylene blue for a reason. And the reason is that many patients who are coming to the hospital for the elective surgery, like a bypass surgery, many times they are using a lot of antidepressant and SSRIs. And at least I have encountered 2 for sure, and third maybe with the serotonin syndrome, because either it got missed or overwrited and nobody thought about it, and patient was given methylene blue. And we have seen severe cases of serotonin syndrome. Personally, I found the Cyanokit is more effective and has less interaction with other medications. So if we persistently see that despite giving volume, despite giving 2 pressors, some of our patients who have some cardiac insufficiency, our anesthesia folks have started epi, so they're already on 3 pressors, epi, vaso, nor-epi, and still I have a lower MAP, low SVR. Then our first line, and I think that that's better than methylene blue, is cyanokid, hydroxycobalamin. And if that doesn't work, the chances of methylene blue working, it's low. And that's where you are encountering refractory vasoplegia. So, but people have used 2 doses of cyanocobalamin, and if that doesn't work, have tried as a methylene blue after that. Now, talking about when all this, if cyanokit is not working, methylene blue is not working, we have another in our armor, we have another drug which is called angiotensin 2. The trade name, I don't know you allow us to use trade name here or not, but it's called Giapreza, and I usually call it angiotensin 2. Angiotensin 2 is well known for a long time, and the reason I think it works also well in cardiac surgery patient, though our study is done on the more on the septic patient, because in the pathophysiology of vasoplegia, there's a lot of role of renin-angiotensin aldosterone cascade, which we call it a RAS cascade, and that's why the AC inhibitor is also a risk factor for the post-cardiac surgery patients. So angiotensin 2, we have used it with success as a when the even cyanocobalamin and when the methylene blue is not working, so we have used angiotensin 2. Said all that, talking about all the treatment from IV resuscitation to talking about the angiotensin 2, if you ask me what you need a lot of patience. And time is actually the greatest healer of the vasoplegia. That sounds very philosophical, but I think that you have to just stay on top of the things that when you keep perfusing the organ. And as one of the anesthesiologists from Africa, I was visiting Africa, and he said that your best management could be a poor man's Swan-Ganz catheter, and poor man's Swan-Ganz catheter, he meant the urinary output. So as far as your organs are perfusing and you keep trying, eventually the vasoplegia takes a lot of time.
That's a good point. And I think that with these non-catecholamine agents, or let's say non-conventional, I just want to emphasize a couple of things that you said. First and foremost is that it's the hydroxycobalamin that you go to first. It's 5 grams, I guess, infusion, right? And you might repeat it one time. So that's not titrated. It's a one-time dose trying to replenish or trying to inhibit your granulocyclase and your endothelial nitric oxide production, right? So it's a one-time thing or two-time thing. The other thing you mentioned, Iqbal, that I think is super important is you mentioned angiotensin 2, which is approved for refractory shock. I mean, we can use it in this conversation, obviously, commercial names, because there is no other angiotensin 2 right now. It's just, the commercial one available. A lot of our pharmacy colleagues have been a little bit shy with that just because of pricing, right? And I think it hasn't been shown to be any better than what we usually use. But when those conventional vasopressors are not working, this might be something that you use. And like you mentioned, it's an angiotensin 1 agonist, which seems to be inhibited in vasoplegic syndrome. So it makes sense to try that. And that I guess that's a continuous infusion, right? You start, I believe, at 20 nanograms per kilogram per minute, and you infuse titrated to MAP, correct?
Right. And then you can, if 20 is not working, and you go to 40, and if 40 is not working, you can go to 80. Here, one thing I will say that one thing, and that was coming from the conversation yesterday with my colleagues, is that if people have to respond to angiotensin 2, you will see some response in the beginning. We go from 20 to 40, we go from 40 to 80, but if you're not seeing response at 20, the chances are that you might not see that response at 40 or 82, and that patient may be refractory to angiotensin, and some other underlying pathophysiology is going on. So I start dreading myself when norepinephrine and the vasopressin combination doesn't work for me. I know that I'm on a long haul for that, and there is some different pathophysiologies there, and I may be going a long course here.
The other thing that I wanted to reemphasize was a little bit on the methylene blue. in terms of just because I think a lot of people probably remember methylene blue associated to vasoplegia. And like you mentioned, Iqbal, the literature we don't have any good studies to say, oh, this is what we should use, right? There's anecdotal reports, but what you mentioned, I think, is super important that often clinicians who don't use it frequently forget is that it is associated with real side effects, right? And that you mentioned the serotonergic syndrome, which has been well described, and with an increase in many of the outpatient psych medications, that can be something we have to be very careful with. I also believe in people who have a 6-GPD deficiency, it can cause severe hemolysis. That is something that we usually don't think about, right? And I think the other thing that people forget, which is a problem that you already mentioned with vasopressin, is that it can cause significant splanchnic vasoconstriction and ischemia, and that can just add, problems to our patients. But when you do use methylene blue, how do you dose that?
We usually give a bolus dose of 120 to 150 microgram, and then we just continue the drip. And I usually ask my pharmacy colleagues to help me out there. Now, other thing which, as you mentioned, which we don't think about it, that many of our patients in our institution and many tertiary institutions, there's a lot of use of INO, intrinsic nitric oxide, for when patients having a RV failure or patient having a high pulmonary pressure. And when you use INO with methylene blue, it negates the effect of each other. So that's another thing people in tertiary care centers, which the intensivists who are working in tertiary care center, they have to be mindful that if INO is on board, you probably better avoid the methylene blue.
Perfect. So we talked about conventional catecholamines, after fluids, optimization. We talked about non-conventional vasopressors, hydroxycobalamin. Can you make some comments? Other things that I know have been mentioned in the literature, and I just want to know your thoughts, are hydrocortisone or corticosteroids and vitamin C, which seems to never go away. What are your thoughts, and where do we stand on those today?
That's true. And this is the treatment which I call adjuvant treatment, or the simultaneous treatment while you are working with pressors and you are working with cyanokit and all this thing. Most of this patient, when come out of the cardiac surgery, they have available the NG tube. So personally, if I see that I'm going towards refractory vasoplegia, I start midodrine. And steroid, you know that it's a topic where half of the intensivists are pro-steroid, and sometimes you find people half are anti-steroid. And when you are managing post-surgical patient, especially post-cardiac surgery patient, you might not even have sometimes time to send a lot of labs. So in that kind of situation, I have used many times hydrocortisone, and just only 50 Q8 hours. And if I know that patient has a renal failure, I have used Florinef also. So these are all simultaneous treatment. We don't know, truly speaking, they work or not. And because they are simultaneous and adjunct treatment, we don't know the pressors are making it better. Our cyanocobalamin 5-gram bolus is making patient better. But I think going after immediate acute hours, passing 12 hours, passing 8 hours, midodrine and maybe hydrocortisone just for 24 or 48 hours, 6 doses of 50 milligram Q8 hours. It helps to sustain what we have achieved. So I use personally in my practice, if I have refractory vasoplegia, hydrocortisone, I have used midodrine, and if renal failure patient, I have added Florinef. I have done that. As far as vitamin C, when it came out, there was a lot of waves and lot of talk about it. I have seen a lot of blogs, both in favor and both in against of vitamin C. And we have mentioned in our article also about the vitamin C. But if you ask me that question, if you have asked me the question when we were preparing that article, I would say that, yeah, if nothing is working, use vitamin C. But after that, we have studies which have shown, and now it's pretty much settled the issue that vitamin C doesn't work. So I may have used one time or two times when it comes out and I was in a situation of refractory vasoplegia, but I stopped using it, and I will not advise. And I will say that that's how the our learning ramp is. This first we get, and we have been in critical care with this learning ramp so many times with so many things. I don't want to bring a lot of past stuff we have learned by our failures. But I will say that this is one of the things which is we tried, we failed, and I will not go towards personally. I don't think that, I think this with all this studies coming afterwards, the issue is settled that vitamin C doesn't help. And it's a large dose. It can cause more renal. It can cause actually harm. That's how I see it. So I will not use it.
Perfect. So I think that really very interesting discussion, Iqbal. You gave us a lot of good advice here. As we close, are there any pearls or pitfalls you want to make sure we re-emphasize for our clinicians?
One thing which I always tell people that don't treat numbers, treat the patient. You will have a Swan-Ganz catheter, which is itself maybe having a lot of artifact going on there. If somebody put the numbers on the monitor wrong, you may have wrong numbers there. So it's numbers are there to help you. But seeing the patient, seeing that patient is clinically doing simple stuff like patient is making urine, patient blood pressure looks better, those simple vitals. So use your clinical judgment rather than going towards only one number or so that's number one thing. Unfortunately, with the advent of the numbers and we are getting more and more hooked to the computers, we are doing less and less physical exam. So frequently, especially in this subset of patients who are vasoplegic, going to the patient bedside, putting your hand on patient pulses, on the periphery, on DP pulse, radial, putting your hand on patient belly that is soft, listening to the heart sound, looking into the heart rate, all these things. So more physical exam and treating patient. That would be my simple advice, but I think this goes a long way.
You did mention at the beginning and throughout our conversation, Iqbal, that obviously there's still a lot that we have not figured out with this particular clinical syndrome of vasoplegia after cardiac surgery. Any comments on what you're excited about or any studies that are ongoing for the future or things that we really need to figure out?
Right. So yesterday I was talking to one of my colleagues and they are interested asking us to join. It's called the REACT Shock trial, which is based in Australia and New Zealand. And that's what they are trying to look into the optimum map. That's one I'm very excited about. And the second one, which going forward, I think we need to figure out either by studies or either by doing some lab work, that I see that if I get a response to the pressor early in the course, this vasoplegia is reversible. So we have to come up by this time working together, finding some grading of the vasoplegia, grade 1, grade 2. So it guides clinician like grade 1 if patient responds to low dose of pressors, and grade 2 if patient does not respond to pressors but respond to cyanocobalamin, or grade 3 or grade 4 where everything is refractory. So we have to come up with some grading. We can work with Society of Critical Care Medicine or other societies, but we need to work a lot more on that side. But I'm very excited about the shock trial which may happen at Australia and New Zealand.
Perfect. Well, I think that this has been a very instructive conversation on a topic that maybe not all our listeners are super familiar with because they might not have the volumes that you manage at your institution, Iqbal. So I really appreciate you sharing your expertise. But as we close, we would like to ask you a couple of questions that are unrelated to the clinical topic. Would that be okay?
Oh, absolutely.
Excellent. So my first question relates to books. Is there a book that has influenced you significantly or books that you have gifted often to other people?
You know what? One book which I advise all of my students who walk into the ICU and they ask me, and many times I got this question from students, which book they should read. So I give them two advice. One book which I consistently tell people to read and have it is Manual of ICU by Dr. Marino. That one book in the beginning of my career helped me. And it is very simply written and easy to understand critical care. But going forward, I have realized that now the way our medical literature is evolving, it has become more important to manage the information rather than getting the information. Garbage in, garbage out, as they say. So we have so much resources now available, and everything is available on our hand tip with our cell phone. You can quickly Google stuff. You can quickly see things. You can go to the up to date. You can look into the PubMed. So learn the most important skill, I think, being a clinician for us is to learn to manage the information, that which informations are important, which are relevant. And unfortunately, lot of since anyone can now publish, there is a lot of junk going on inside our literature. So to know that which information to target, which to read, and which not to read, that's extremely important.
Excellent.
One book which lately I will say that I was reading, and I was very much impressed. One thing which we don't pay attention is a concept called pathography. Pathography is a concept where you try to see the disease from the patient perspective. And lately we have seen a book coming out from Dr. Eli, who has done a lot of work in delirium. He did deep down breaths. So thinking of disease from the patient perspective, or the book Shock came out from one of our colleagues from Cincinnati. She was in hemorrhagic shock and was admitted in ICU, and she wrote a book about her experience. So I think lately the concept of pathography and the books which depict the experience from patient's perspective is really something giving me more passion about the patients.
Excellent, and we'll definitely link all these recommendations in the show notes. The second question is about, they say that a measure of intelligence is people who are able to change their mind when they're faced with new information. Could you share something that you changed your mind about over the last couple of years?
I have done it. When I started my career, I was very much sold out to the evidence-based medicine. But as I evolve and as I learned two things. One is that it is very important to know on the bedside what to do, and we spent last 1 hour talking about what to do when the vasoplegia happens. But I also am learning over the time that it is also very important as a clinician for us to know what not to do. And sometimes we do things just because somebody said so, and we can harm the patient. So that's number one lesson. Number two lesson is that your clinical judgment is extremely important. You have all the resources, you have all the numbers, and we are spoiled in United States, and especially in where I work in a medical center, we have a lot of resources, medication, everything on our hand tip available. But your clinical judgment should supersede and as you get experience, and there is a word for it that's called factor of extra information. Being a physician, you have with your experience of extra information, which sometimes you can't explain. So more and more work towards putting everything together: patient, your clinical judgment, and your numbers. Just not go with only one thing. That's what I am evolving.
And I think to your first comment that you made of doing things like that almost bias we have to do things and say, well, what do we have to lose? Well, you gave a perfect example with methylene blue. If you develop a serotonergic syndrome, you just made a bad problem worse, right? So
exactly.
You do have complications, and doing things does have a price often for our patients. So I think that being a little bit more cautious and thinking about that is also very important. So I think those are excellent lessons for the audience. And to close our conversation, is there anything you would want every listener, every intensivist who's listening to know? Could be a quote, a fact, or just a thought.
You know what? I always think of a quote from Carl Sagan, and he is a cosmos person, and he has said a beautiful thing. And I always think about when I'm on the bedside that absence of evidence is not the evidence of absence. So that's a very profound quote, that sometimes if we don't see anything, it doesn't mean that it's not there. And the most frustrating thing for a clinician is to not know that what he's dealing with. So being a clinician, my advice is that continue to, even sometimes we just think in our mind. I will just give a simple example, that patient comes with acidosis and patient is diabetic. And we just, before seeing patient, sometimes we make up our mind that patient has a DKA. It may not be a DKA, it may be something else going on. So having a preconceived notion or making judgment very quickly on the patient, on the diagnosis, continue the treatment, continue the management, but continue to look for something which you may be missing. So be on constant strive. And one in this regard, I give one advice to all my students. We all have CV of success. But going home every day, driving back, also think that what you have not done right today, what you could have done better. It is, being a clinician, the best thing you can have is a satisfaction in your heart that you helped the patient, you did something right. But it's also important to know that what you haven't done right, what you could have done better. And that's called CV of failure. So knowing your CV of failure is also important.
Iqbal, I want to thank you for a wonderful conversation, for sharing your time and expertise. I think this is the perfect place to stop. I hope to have you back soon. Okay.
Thank you, Sergio, and inviting. It was a great pleasure talking about this topic, which is very near to my heart.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.